some of the studies that show some longer-term follow-up suggest that these early benign results probably deteriorate with time. And so it probably is worth our while to try to find ways to improve healing. Now, when we look at tendon healing, there's a number of issues that it depends on. First of all, good surgical technique and fixation, and then the essential biologic response, and the stresses on the repair during that healing period post-operatively also play a major role. The biology continues to be a challenge for us, and ultimately that is something that we should have better control over. There's a lot of research being done currently. But right now, the main thing that we have a lot of control over is our surgical technique. And so we need to make sure we're optimizing that. So the concept of anatomic footprint restoration with double row technique has become more popular in the last few years. It's been shown that it's a more anatomic repair. Many studies have shown it's stronger and provides a more rigid fixation. So theoretically, this seems like it may improve the chances for good healing. If we look at some of the original studies, we learned that the insertional site for the supraspinatus is actually a very broad area, measuring about 14 millimeters from medial to lateral. And with a simple single row fixation technique, we can restore only about 46% of that original footprint area. Whereas with a double row anchor technique, it is possible to fully restore 100% of that original attachment site. And looking at the mechanical studies, there's been a number of studies, including our center, Ma, Kim, Smith, on cadaveric specimens using different cyclic loading protocols, showing that double row mechanically is much stronger than single row techniques. Lorbach in 2008 did a porcine study showing double row stronger than single row. Ahmad in 2008 also used a novel rotational testing method, a slightly different way of cyclic loading, to also show double row being stronger than single row. On the other hand, Mazuka in 2005 did a mechanical study and did not see a difference between single row and double row as far as strength. And Mahar and Nelson did studies also showing no difference. These were done with animal specimens, unlike the other studies with the human specimens. Most recently, we have a paper in press using a unique method of testing to assess micromotion at the repair interface. And we found that the micromotion is much less with double row versus single row and transosseous. Again, theoretically, providing a better environment for healing. And even more recently, the standard double row technique has undergone some innovations, and we see some experts suggesting that a suture spanning method is even more superior to a standard double row technique. And this is where we have a medial and lateral row and suture spanning in between the rows. It's also been known for a number of other names such as suture bridge and a transosseous equivalent technique as well. These are all referring to the same thing. Now, Park and colleagues have done a number of mechanical studies on transosseous equivalent, and with a standard cyclic loading protocol, they've shown that the transosseous equivalent was actually stronger than the standard double row. In another study using that rotational testing method also showed superiority of the transosseous equivalent. And their explanation for why this might be occurring is due to the interconnectivity or load sharing between the implants. When we see a standard double row technique, each of the suture anchors is an isolated entity. And when the arm is passed through a rotational motion, different anchors are faced with a different amount of stress concentration. And so the leading anchor with rotation of the arm can be subjected to disproportionately higher amounts of tension. Whereas with a suture spanning type of arrangement, because all of the implants are interconnected, there is perhaps a more even distribution of the forces on the tissue throughout the range of motion. Dr. Sano and Itoi from Japan had a study using finite element analysis to measure stress distribution within the tendon. And they found that dual row and single row anchor repairs, essentially suture anchor repairs, concentrated the stress in the tendon at fairly high levels, whereas a transosseous suture repair tended to distribute that force more evenly across the tendon. Park and colleagues also did a cadaveric study doing a what they called a modified double row. This is essentially the suture spanning, and did TechScan pressure monitoring, which is continuous pressure monitoring throughout the range of motion of the arm, and showed that the suture spanning method provided better contact throughout the range of motion. Lorbach, again in 2008, though, did a study, and they showed that the suture spanning was less strong than a standard double row technique, and was equivalent to a modified single row technique that used a modified stitch similar to an arthroscopic Mason Allen. This was an animal study. However, push-lock anchors were used, which tend to have a lower pull-out threshold than some of the other knotless anchors. So these may be some issues with that. Now, of course, theoretically, double row seems quite attractive, but there are a number of concerns with using this technique. First of all, the potential for over-tensioning the cuff is a real issue, particularly with chronic retracted tears, and especially if there's been tissue loss. By fully lateralizing the rotator cuff, we may be in jeopardy of over-tensioning the repair, which should be forbidden, of course. This more complex technique takes increased surgical time, and also there's an increased cost of using additional implants. And so of course, we'll need to have good data to substantiate these additional concerns. And so the clinical studies will be very important to see if our theory actually matches up with reality. Now, we have a number of clinical studies we can look at. LaFosse in 2007 reported on his series using CT arthrogram follow-up and showed a relatively high success rate with double row. I believe it was in the 80% rate of healing. Hugemans in 2007 also, using ultrasonography, showed a high rate of healing, about 83%, and this is including large and massive tears. The only problem with these studies is that there were no control groups to compare. Dr. Sugaya from Japan had a study back in 2005 using post-operative MRI and showed single row had a 25% rate of re-tear, whereas double row had only a 9.8% of re-tear. However, when he looked at functional scores, he did not detect a difference. Charwasay in 2007 did a prospective but non-randomized study, CT arthrogram post-operatively, and showed that the anatomic healing was better in double row, but again, they did not find a clinical difference when they looked at the constant score. Francesi in 2007 did a very nice study. It was randomized and prospective, although the patient groups were relatively small, but they did the MRI follow-up and concluded that although they thought double row was a superior mechanical construct, that again, they found no difference in the clinical score. More recently, Burks in 2009 just published another randomized prospective study, 20 patients per group, again relatively small, and they found no difference between MRI comparison or looking at clinical scores. And Grasso in 2009, another randomized prospective study, slightly more patients, 40 per group, 2-year follow-up, and they used a number of different criteria for measuring the clinical result, and were not able to show a difference clinically. So when we sum up all of these studies in the literature, to make sense of this is somewhat challenging, but I think we can say at this point that using objective measures, post-operative imaging, that the healing rates with double row tend to be somewhat better than single row. However, the functional results have not been shown to be different between the two groups. And whether with longer term follow-up, because many of these studies have relatively short follow-up, this may change, but of course this will require much more study in the future. So I'm just going to share with you my own personal approach and how I deal with this information that we have in my own practice. And I'd like to emphasize that as we know, rotator cuff tears come in a variety of shapes and sizes. It's not just one entity. They're all a bit different, and I think it's important that we individualize our techniques with the patients and not just have one surgery that we do on everyone. So I would discourage people from using a so-called cookbook approach and kind of customize the surgery to each patient depending on the type of tear that we're dealing with. When I use a double row technique, I've been using a suture spanning technique, using a Meier helix anchor for the medial row and a Versalock anchor for the lateral row. The helix anchor is nice because it's a fully threaded anchor. It's a newer generation implant with a high number of threads for increased pull-out strength. It actually has a dual thread pattern, so it engages both cortical and cancellous bone. And because it's fully threaded, it can be inserted just to the cortical surface. And this addresses some of the important considerations with some of the more conventional anchor designs. The more conventional anchors require to be inserted fairly deep in the bone, in the cancellous bone. But what can happen is that with loading, the suture can cut through the bone as it seeks the shortest path between the 2 points. And as a result, though, there can be gapping at the repair site. With an anchor of this design, because it's inserted just to the cortical surface, the strength of the implant prevents that cutting out from occurring. And furthermore, another issue is anchor migration. When the anchor is placed in the cancellous bone, if the bone is soft, it will migrate with tension up to the cortex, and then it will usually stop at the cortex. But the problem is the head can become proud, and of course gapping can occur again. So a fully threaded anchor like this will tend to resist that migration. The Versalock is a nice anchor for a knotless configuration. This is threaded with the suture on the outside of the joint and then implanted into the lateral row position. The suture is tensioned and then the implant is deployed, capturing the suture on the inside of the implant. And here's how it works here. And we've done actually some mechanical testing showing a favorable profile of strength. So the technique I usually use involves using the helix anchors in the medial row. I usually have double suture loaded anchors, do a double mattress stitch, and then use the suture limbs to span laterally through the VersaLock anchor, which is implanted in the lateral row position, and the sutures are tensioned and then locked down into place in a sort of a crisscross configuration, which compresses the tendon against the footprint. And one of the reasons, the rationale for this treatment, particularly with very chronic tears where there can be a very profound osteopenia in the greater tuberosity, which can create a great challenge for our fixation. By spanning like this, we can put the threaded anchor right along the articular margin in the dense subchondral bone, and then use the VersaLock anchor in a very far lateral position to take advantage of its cortical fixation, where there's oftentimes just a thin cortical shell, and we can span right across that deficient portion of bone, which helps make this a relatively strong type of fixation. So in closing, we talked about the various issues that we need to keep in mind. Again, the biology is really going to be the key for the future, and we have a long way to go in order to figure out how to facilitate better healing for the rotator cuffs. But at the present time, it's very important that we make sure that we're performing the best surgical technique that we can. And so the question remains about double row repair. Should we use it always? Should we use it never? My suggestion would be maybe neither, but let's be selective and individualize our treatment based on the information we have currently until we learn more. I would consider double row in patients, particularly if they're undergoing revision repair, if they already have implants in the bone. This is a way to span across the areas where there may be a cyst formation with the old implants. If a patient has a poor healing potential, if they're tobacco smokers, diabetics, or they're on chronic NSAIDs for other conditions such as arthritic conditions, and if healing is a concern. Also, if they have risk factors for stiffness and we want to be more aggressive with their post-operative rehabilitation, we may want a more durable repair. Or if a patient tends to be non-compliant, this may be a good idea. But it's best to make sure that the tears are fairly mobile and we don't have a lot of tissue loss, because we don't want to make a mistake and over-tension the repair. And I will do a single row repair, particularly with chronic retracted tears with minimal mobility if there's been tissue loss. But I'll do a more advanced single row technique, such as Dr. Ree spoke about earlier, with a triple loaded suture anchor or an arthroscopic Mason Allen stitch for increased strength. And I will also consider a decelerated rehabilitation protocol to protect this more fragile fixation in the healing period. Thank you very much for your attention.